Welcome to Valley View University. I would like to thank everyone for joining today. I have a few housekeeping items to address before we get started. You can submit any questions through the Q&A on the bottom of your screen. Your question could be answered during the presentation by physician assistant Ashley Gilly in the Q&A chat or live at the end of the presentation. We are unable to answer questions regarding personal health information. I'm excited to share with you general urology topics. My name is Dr. Kabra, specifically natural urologic changes in men over time. I've had the unique opportunity to be a Rocky Mountain urologist over the last 5 years. And along the way, I've garnered a lot of experience and anecdotes from you all, our patients and community, that I will try to incorporate throughout the presentation. Another concept is there is an idea that aging of an organism or humans is a combination of aging of individual cells over time. And that is a recurring theme that will come throughout the presentation as well. Rocky Mountain Urology is a unique and wonderful place to practice. It's built on a legacy of flagship of excellence throughout the region. From Vail to Grand Junction, Meeker and Rangeley to Aspen, we serve over 4,000 square miles and are the only 24/7 urology service line offering regional cutting-edge care. Through the years, our team has continued to expand with our highly skilled staff, growing alongside our providers with in number, experience, and expertise. And in my humble opinion, propelling us to become the premier urologic practice in the state for most of general urology. This is another concept I'd like to discuss in how we approach medical care throughout our community and region. And that is, simply by living here, we all get to live longer and add significant years to our lives. Summit, Eagle, and Pitkin County, on average, live 10 years longer than the national averages, and Garfield County is close behind. Men are living up to average of 85 and women even 90 years of age. This influences how we need to view ourselves, how we need to deliver care. As providers, we need to think outside the box and think about how we are going to live our twilight years. We need to focus not just on longevity of life and quantity, but quality. And it's important that our doctors and physicians, we think of our patients and doing the activities they love to do, such as skiing, the great outdoors, whatever we like to do. And that's why it's important, I think, for patients to partner with healthcare providers and teams that understand this about them and our communities. It's hard to fully describe how awesome it is to be a Rocky Mountain urologist. Every day, I get a chance to come in to meet people who inspire me and amaze me. You all are living harder, better, more life experience and doing things I could have never imagined. You all show us the way, the playbook, the habits, and the mindset we need to adopt to extract the most out of the human journey. The mountains are a unifying theme, and it's a constant foundation for finding common ground. By the end of this presentation, I hope you also find that urology is a unifying theme amongst us all. So, a review of the male genitourinary anatomy. These are the organs we will be covering today. In general, we can divide the upper urinary tract, which consists of kidneys that make urine that drain down to the bladder, and the bladder below the lower urinary tract, where in the pelvis, we also find reproductive organs. So let's stop kidding around and get into it. The kidneys are essentially two blood waste treatment plants in our bodies. As a result, we need rapid, high volume, frequent blood flow to perform this function. And with each beat of the heart, the kidneys get 25% of the cardiac output. The kidneys function is also designed to maintain numerous systems in regulation throughout the body, including our fluid volume status, electrolytes, acid-base balances, blood pressure. It's also a hormonal organ that's responsible for energy systems as well as red blood cell production. At the core of the kidney is in each unit called a nephron, which is essentially a blood treatment system that generates urine. There are approximately 1 million nephrons per kidney with wide ranges per individual. For reference sake, the US has only less than 200,000 water treatment systems. So you can imagine how complex the kidney really is. And we see here some of the anatomy that's over years and years of evolution of the kidney nephron unit has made it one of the most complex, daunting systems to study and really understand in medicine. One of the important concepts here is that the kidneys cannot generate new nephrons. And over time, due to aging and various conditions, we gradually start to see less and less nephrons. I'm always left in awe at how important our kidneys really are. Aging can also be known as senescence. Senescence is a concept of mild changes over time, not attributable to any specific disease, that is just accumulating. And we see this at the cellular level too, where cells are neither replicating nor dying, but just hanging around, becoming more inefficient. And one of the key concepts here is senescence of the kidney and nephrons. And when we combine that sometimes with pathologies such as diabetes and high blood pressure and other damaging entities, we start to see an acceleration of kidney disease. For example, during COVID-19, we saw more viral illness of the kidney superimposed already on aging kidneys. And we get buildup of damage that can occur. So why is this happening over time? Well, there's various theories. Some is that there's genetic programming for these cells to stop functioning well. There's also buildup of external toxic molecules such as reactive oxygen species, methylated products. And this chronic kidney disease entity that we oftentimes hear about is still elusive in that it may be a disease of aging, it may actually be a disease in and of itself, but it's likely a combination of these elements. Another thing that happens over time is our human body water composition changes, and we actually get less body water composition. And as a result, we have decreased thirst mechanisms in order to replenish that. But because we have lower reserves to start off with, we are very prone to dehydration as we get older. In fact, it's a common cause of admissions to the hospital and ER visits, as well as causing many urologic entities that we see, such as kidney stones. And in general, we see many age-related changes, structural changes as urologists, such as cysts, tumors, both benign and occasionally cancerous. So what can we do for our kidneys to make sure that we reduce the influences of aging on them? Well, as mentioned before, the kidney is essentially a cardiovascular organ. Everything we do for our heart, our brains, also applies to the kidney. And that includes controlling your blood pressure, ensuring there's no diabetes, managing cholesterol. Exercise has been shown to have cells more resilient to the changes of aging, oxidative stress. As well, aerobic exercise and anaerobic exercise may synthesize excess protein as well. So both types of exercises are recommended to maintain kidney health. Of course, we discussed the need to drink water to avoid dehydration. And in general, the same diets we recommend for cardiovascular health, such as more plant-based options and reducing less animal protein and fat, also apply to the kidney, because these nephron units are very sensitive to changes in filtration. And if there's excess protein and filtration, it can damage the kidneys over time. Next, we'll talk about prostate. Prostate, of course, is in the global news recently and has led to a lot more discussion and awareness of issues that can arise. So what is the prostate? The prostate is purely a reproductive organ. It sits right beneath the bladder. Your urethra, where you urinate through, goes through the center of it like a donut hole through a donut. It's just a channel, not a discrete tube with walls. Its function is really to produce fluid that contributes to semen that's necessary for fertility, as well as helping the expulsion of semen during ejaculation. The issue is that the prostate is likely not designed to function like this forever, as we're likely not designed to reproduce forever as well. So natural deterioration starts to occur to the prostate. There are two main forms of deterioration. One is benign prostatic hyperplasia, which is a benign non-cancerous growth that starts to grow to block the urinary channel, and men can develop urinary symptoms. The other issue that occurs in prostate deterioration is prostate cancer. We see this and screen for this with PSA blood testing as cancer disrupts the cell lining of the prostate, releasing more PSA into the bloodstream. Let's talk about BPH, or benign prostatic hyperplasia. As mentioned, this is a disease of aging for men in prostates as we get older. And as a result, it affects us all virtually to some degree. It's the number one reason why men visit urologists. Virtually every man will have some impact of this over their quality of life and potentially urinary health over their lives. So in general, it's something we all need to be aware of. What is prostate cancer? This is a complicated question and one we could spend the entire hour on in and of itself. However, cancer in general, when it applies to prostate, should not strike those fears, anxieties, and emotions that the word cancer in general typically is associated with. Prostate cancer is usually just a biological finding under the microscope. It is simply describing the architecture and pattern and shape of the cells, and not predicting a clinical prognosis or issues that could arise. In fact, this is something that over the years and decades has led to so much confusion and distress that recent movements and discussions are revolving around reclassifying and simply rephrasing this word from cancer to other words, such as neoplasm or atypia or incidental finding. There are some cancers that, of course, that are aggressive, but in general, the old adage that most men die with prostate cancer, not of, is true. And that's something we simply need to be aware of and not overreact to. Prostate cancer epidemiology. This is an important slide with a lot of information that I'll spend some time on. Aside from skin cancer, prostate cancer is the most common in men. There are approximately 300,000 new prostate cancer cases in the US, as well as 40,000 cases of death from prostate cancer predicted in 2024. It can be a serious disease, but most men diagnosed with it do not die from it. In fact, millions and millions of men in the US have been diagnosed with it that are doing great today with no issues as well. And that's what we usually expect and is always our goal. Prostate cancer starts to arise in our 50s, 20% of men, 25% of men in 60s, and 35% of men in their 70s, and it exponentially increases into 80s, 60, and 70% of men. This chart here has a lot of information. We can see here over time the history of prostate cancer and urology. Specifically, we start to see an increase in prostate cancer diagnoses as the advent of PSA, the blood test screening tool, becomes adopted and widely used, peaking in 1994. And subsequently, as a result of this PSA blood test screening, we see a drastic decline in advanced metastatic or distant stage prostate cancer. So this is good. We see that prostate cancer screening with PSA is saving lives, less aggressive disease. However, a concern arises in that maybe we are over-treating men. Maybe the side effects may not be worth the treatment. Is it worth the cost of the healthcare system? So in the early 2008-2009 timeframe, several governing bodies started to reverse their decisions on recommending prostate cancer screening. And we actually saw less incidence of prostate cancer being detected. And it led to confusion as well as a lack of inaction sometimes, leading to less PSA screening. Unfortunately, we started to see a 3 to 5% uptick annually of distant metastatic prostate cancer as a result of less PSA screening. So then several of these governing bodies, again now in the late 2010s, started to say, let's reverse our decision and recommend potential PSA screening. And in general, there has led to a lot of confusion and misinformation, perhaps. The bottom line is many governing societies are now recommending PSA, in fact, even starting at younger ages, because we now know we have better ways to interpret it. We don't overtreat men. We keep many other priorities at first goals as opposed to overtreatment and side effects. So I recommend PSA screening and discussion with your primary care doctors about that. Another interesting note here is that the prostate cancer, when we look at these graphs, many of them are ending at 80 and 85. But as we mentioned in our patient population, we need to extend this further for the age range. And as we see, as we actually detect prostate cancer later in life, it becomes a bigger and bigger issue as a cause of potential death. Meaning we need to do an even better job of looking for this, finding the right time as we get older, perhaps in our patient community. So what causes prostate deterioration? Extremely complicated topic, multifactorial, multiple causes, but in general, I will try to highlight some of them as they are common questions. Age, of course, as I mentioned before, we're likely not designed to live forever, and there's reproductive clocks within us all. We see similar deterioration in women and their reproductive organs, such as breast, ovarian, and cervical. And I believe prostate is a similar homologue in men in terms of a reproductive decline. Genetics have a big component between ethnicity and family history as well. And it's not just a history of prostate cancer, but history of breast and female-related cancer, reproductive cancers that can be risk factors for men. So it's important to keep that in mind. Obesity, metabolic syndrome. In general, these are states of excess energy and overgrowth that cause hyperinsulinemia, insulin-like growth factor, increased estrogen that can lead to more aggressive and more advanced disease on presentation. Diet and nutrition. This is, of course, an even more complicated topic that can sometimes be even difficult to approach culturally. However, the general thoughts and themes is that when we are in a state of energy excess, there can be more growth and more cancers. And when we look at long-term longevity populations, we find that in general, mild to moderate caloric restriction translates to longevity, and we see less incidence of prostate cancer as well. Most observational evidence suggests that the general cancer prevention diet, as well as cardio, neuro, renal protective diets, recommend more plant-based caloric options and minimizing animal protein and fat. In prostate cancer specifically, there's stronger evidence it reduces death and progression from prostate cancer. There's another interesting observation I thought I'd share is we know that men that come from Eastern countries such as Japan or the Middle East have much lower incidence of BPH and prostate cancer. However, if we take those same men and move them to America and expose to the Western diet, we start to see similar rates of prostate cancer, BPH, and in their first generation born Americans. So diet likely affects the risk of getting some prostate deterioration to some extent, but it's also very complex to interpret, as the Western diet is a wide range. There's genetic components, of course, and confounding behaviors with a healthy diet that can be found as well. You may read about things online such as dairy intake, vitamin D, increasing fish and tomatoes to have more vitamin D and lycopene as well. And there is some evidence for these, but they are controversial. One unique risk factor that also presents is hormonal based. And in fact, when we think about some of the development of us in men, and we try to forget the time we call puberty when we are growing taller and going through rapid hormonal changes, we've actually found that, in fact, being taller can be a risk factor for prostate cancer. And that suggests that the testosterone, dihydrotestosterone expressions at this point in life and where they peak may be perhaps one of the risk factors and predictors for issues with prostate cancer later in life. We see hormonal changes happen throughout our body. The prostate is one of those very interesting organs, reproductive, that responds to testosterone its entire life, unlike other reproductive organs, such as the penis. The prostate can continue to grow throughout life because of this unique attribute. We also see the hormonal profiles change over time, meaning we see more dihydrotestosterone in the prostate. On average, the prostate can grow 6 grams a year in men over age 40. And we have visual indicators of this hormonal change too. As men, as we get older, we lose our hair on our head, but are able to grow bigger and grizzlier beards. And this is a direct influence from this hormonal change. So, what is the final frontier of the prostate? Well, it's so complicated and so individualized with so many variables going on that I do think when we figure it out, it could be the greatest Nobel Prize of all time. In the not so distant future, I think that with combining a lot of these variables and the need for AI modeling into the future, we'll be able to develop at a young age a forecast of how we need to individually screen, individually approach reproductive health and reproductive protocols for men and women. And hopefully that's not too far along. But again, I'm a biased urologist, so it's my job to be forward thinking. All right, let's change gears into the bladder. The bladder is essentially a pump for urine. Its goal is to store urine at a low pressure, and as time goes on, and its bladder fills up, it'll squeeze to expel that urine. And we call that act micturating or micturition. One unique attribute of the bladder is it is a smooth muscle. It's not a muscle like your bicep or tricep. The smooth muscle is designed to work at low pressures and not be overworked. I like to describe 5 stages of bladder health. If you recall, we were talking about BPH, or benign prostatic hyperplasia, which starts to block the urinary channel, or that donut hole collapses. And the urinary symptoms men can develop can be pretty classic for this phenomena. They get weak or intermittent stream. The second stage of bladder health can be that pump, which is now squeezing against the clogged pipe, has to go into overdrive, and it leads to urgency, frequency symptoms. It can get so out of control that bladder starts going off on its own, even a little haywire, that you can get leakage of urine before or after urination. And the thing we of course want to avoid is that pump gets so overworked, so overclogged that it starts to give up, and you can end up with infections and catheters. And if left completely unchecked, this can lead to a permanent bladder dysfunction, where even more severe issues can happen, such as having to live with a permanent catheter, which of course nobody would want. This is a brief depiction of the bladder life cycle in terms of its pressure and flow. And what that means is, ideally, the bladder is generating great flow of urine at low pressures. We don't want it to be overworked. We want it to be easy to get urine out. But over time, as that prostate starts to block the channel, that bladder needs to overwork and generate more pressure. And it'll only do so for so long before it starts to get weaker and weaker. And then we start to see a high pressure bladder, but not generating much urine flow. And eventually it can only do that so long before it starts to give up. We've been able to demonstrate this life cycle to the bladder over age and time, in that, in general, men's bladders start to hold on to more urine after we urinate and don't fully empty. We start to see our flow rates decline over time, and we see our bladders start to increase pressure before they start giving out. So we see these changes as well structurally in the bladder when we examine from the inside. A healthy bladder should have a nice, smooth vascular surface. Over time, as that pump has to squeeze against the clogged pipe, it starts to form ridges, trabeculations, saccules. You start to wait longer and longer You get blowouts in the bladder, large floppy bladder. These areas of dead space and can end up with infections, catheters, and stones. So although oftentimes we go and decide on BPH treatment based on urinary symptoms, this is an important concept to consider of bladder health and bladder health preservation. That the issue here is we can't undo these changes that occurred to the bladder. We can only preserve what we have left going forward. And it's important to think about what is our urologic health in 5, 10, 15 years? What is our urinary health? We don't want guys to end up with any of these issues, but we also don't want guys to have problems doing the activities they love to do, developing problems from that. So this is important to keep in mind that beyond your urinary symptoms, there's a concept of bladder health preservation to consider. Another issue that can arise in the bladder that coincides with aging is bladder cancer. Bladder cancer, the most common sign or symptom is blood in the urine. And essentially, the general advice here is never ignore this and get it worked out. It's part of every annual wellness visit with your primary care doctor, and why it's very important to check in with them. Bladder cancer occurs in a majority of patients over 65 with median age of 70 or higher. And the general thought is that there's a direct chemical insults to the bladder, such as smoking, which is the biggest risk factor, and other environmental exposures, such as benzene compounds, dyes, solvents, even chemotherapy and radiation. Agent Orange in our veterans as well. Bladder cancer can present as a spectrum of disease, from low-grade superficial tumors, and this is how one can look inside the bladder, that can have high recurrence rates because urine cells can easily implant into other parts of the bladder. And occasionally, there can be need for advanced major surgery and chemotherapy as well. So again, stress the importance of ensuring you have your urine periodically looked at with your primary care. All right, now we'll transition into some of the more reproductive and sexual health parts of the discussion. So when I was looking up penis humor on the internet, this is a meme that popped up, and I thought it was pretty accurate, and that this is how most patients come in looking like when they want to come talk to me about men's health. And nervous and afraid, and this is me trying to lighten the mood, break down any barriers, and even use humor to ensure we get to the root cause of the issues. Because the reality is we have many therapies and options that are indicated to enhance sexual health, improve men's health, and as a result, improve the human experience. And as you'll see here in the next slides, when we improve men's sexual health, we actually improve overall health. At this point, there isn't anything you can say or show us that we haven't likely seen before. So no need to come in looking like Woody and Buzz Lightyear here. Erectile dysfunction. It's defined as the inability to achieve or maintain penile erection sufficient for satisfactory sexual performance. And in reality, it's defined by you and what your perception is and what you tell us. It increases with age, where nearly all men over 70 have some form of it. It's one of the most complex processes in the entire human body, involving the brain, nerves, muscle, blood vessels, hormones, and emotions. In general, the way the penis erection works is that there are two main cylinders that fill with blood to cause the erection. There's a third separate cylinder where you urinate through called the urethra that is completely separate and not involved. But you can see here how important blood flow is for an erection to work, as well as nervous control and many other anatomic structures in the region. In general, we like to say, if you have an opportunity for intimacy, the treatments for erectile dysfunction are worth it, as they can be cheap and effective. And we do know that intimacy can lead to longer longevity and quality of life. There can be less cardiovascular issues and less psychological, hormonal, social decline, as it keeps us close to our partners. A big important thing to understand about erectile dysfunction is it's perhaps the first biomarker of your overall health, and especially your cardiovascular health. It's an easy external indicator to see overall how your body systems are working. And if you ever have even mild erectile dysfunction, it's important to check in with your primary care doctor. We want to make sure issues like blood pressure, cholesterol, diabetes, hormonal, and cardiovascular are fully optimized, and we're doing everything we can to ensure there's not a bigger issue such as coronary artery disease or other problems. Every year, I get a handful of guys, probably more, that come in and tell me, hey, doc, it seems like my penis is shrinking or it's getting smaller over time. And after we examine them, I mostly reassure them, and I thought it'd be worth discussing here briefly today. And that is, as us guys get older, as mentioned before, our body composition changes, and we start to have more fat in general in certain areas. And that includes above the pubic bone, in the scrotum even, that can lead to the optics that the penis is actually shrinking. However, if we're able to reduce this fat and see the penile length really rarely changes in length, it's more so a fat distribution. And I really just wanted to bring this awareness so when guys look in the mirror, they understand what's going on and aren't too worried about it. Peyronie's disease. Peyronie's disease has started to gain more and more awareness as in the recent years, including national campaigns, advertising campaigns, and websites like bentcarrot.com. There's a wide variability from 1 to 10% incidence in men over time, which is a pretty high number. And essentially, what is happening is when the penis is usually in an erect state, the elastic tissue that holds the blood is being injured through some micro trauma. We may not even know about it. We may roll over in bed at night while we're sleeping with an erection and mildly injure it. And instead of healing that area with elastic tissue again, a collagen-based scar that is inelastic forms instead. And as we discussed before, it's important for that blood to flow through these areas well. And when we have a Peyronie's plaque that forms, the blood flow does not flow as well. And we start to see curvature or difficulty with penetration. Less sexual positions can be performed. We see shortening or reduced elasticity of the penis, and even a reduced, softer erection beyond the plaque. We can see and feel physical changes in the penis, such as a firm calcification or hourglass indentation deformities. It's important to raise awareness about this, as we have treatments that can fix this. And it is a disease of aging. As we have more repetitive micro or macro trauma to the penis, this can develop more. So it's important to always practice safe, atraumatic sexual practices. Testicles. Two main functions of the testicles: to produce sperm and to produce testosterone. Sperm, obviously, for fertility, and testosterone for numerous functions, to include increasing muscle mass, our sexuality and libido, red blood cell production, our secondary physical characteristics, bone health, as well as the development of our genitalia. Believe it or not, men also experience a gradual andropause over time, or decline in these functions. It's not as immediate, sudden, or striking as women and menopause, and we still have no right to complain about it compared to women, but it's good to be aware about. So I'll spend the next few slides discussing these concepts. We hear sometimes stories of men, and know sometimes men, who've had children well late into their life, including some men over the age of 80. And we think then that men can remain fertile their whole lives and have no issues sexually and can do whatever we want. But the reality is that's not true. We start to see decline in semen and sperm parameters at a relatively young age, including age 35. We start to see less DNA motility and concentration. At age 40, we start to see more DNA fragmentation. And at age 50, we see a significant plummeting in semen sperm parameters as we start to see structural problems with ejaculation as well. In fact, when we look at artificial reproductive technologies, it's harder for them to be successful, such as in vitro fertilization, when the sperm donor is of an older age. So when we look at fertility, we tend to obviously weigh maternal factors, and we also look at birth risks. We think of maternal factors as well. But it's important to remember that having a baby is a team sport, and the father's age also contributes to this. And that in terms of after pregnancy, we have seen babies needing more ventilation or seizure activity or low birth weight in older fathers as well. Now, it's important to understand that the risks of these are still very low, and the relative risk may be a little higher, but the absolute risk remains really low. And the point of this slide is not meant to tell you to drastically alter your life plans or family planning, but simply to be aware that if there is a role to optimize family planning in your timeline, it's good information to have. Hypogonadism, low testosterone. It's a very hot topic. It's been heralded as the fountain of youth, the anti-aging hormone. What does it do? What happens, what do we feel when it starts to decline over time, as we had talked about? It's always important to approach this topic with caution, because the reality is testosterone replacement can make guys feel great, and who doesn't want it? When we replace it, we can improve a lot of the issues that affect men as they get older, such as associated with low testosterone, such as fatigue and mood changes, changes in body composition with more obesity, less muscle mass, breast development, high blood sugar, less libido, erectile function, even bone health, and implications in cardiovascular health as well. We do replace testosterone in select individuals, but it's always important to preface that it needs to be goal-oriented, evidence-based, with a well-defined follow-up plan. The reason is there are significant risks associated with it as well, which we will briefly discuss. But some examples of when we use it in our community are, there may be guys battling metabolic syndrome, even obesity, diabetes, that are having a tough time getting off the couch to start becoming active to counter those issues. And that could help kickstart them. Sometimes men want to match the libido of their sexual partners who are younger age. And sometimes men are noticing that they're not able to do the activities they love in the great outdoors, especially strenuous ones from weight training, uphilling, etc., that they want to consider this. We have used it in cases for bone health as well as mood and depression. But again, it needs to be highly individualized, evidence-based, with the full understanding of the risks. Some of the epidemiology of testosterone is, as mentioned before, at the age of 40, at 1% per year decline in testosterone, and in fact, more amplified decline in free testosterone. We see sex hormone binding globulin start to rise as well, which accounts for this. An interesting observation that we see in generations over time is that men really across the world have started to have lower and lower testosterone each generation. We think there could be numerous reasons for this, but in general, as we've experienced a more sedentary lifestyle, inflammation from diet, less sleep, more stress, more sleep apnea, and even more estrogen exposure, testosterone has declined. We interestingly see similar declines in fertility rates and sperm quality that mirrors this exact same trend. So what are some of the risks of testosterone replacement? Well, they can be significant. It's important to note that it can, in fact, make prostate cancer more aggressive or cause prostate cancer. Now, that is a highly debated research subject, and there is plenty of evidence to show that that is, in fact, not the case. But it's always important to proceed with caution when considering this variable, as I have personally seen cases of advanced prostate cancer where I've only been able to identify testosterone replacement as a risk factor. It can make prostate grow a little faster as well, causing aggravation of urinary symptoms, bladder health, and BPH as discussed. There can be liver toxicity, breast development, and something that's even more unique to our community is thicker blood and increased red blood cell production. Given we already live at high altitude, typically with higher hemoglobin and hematocrit, and then we further add testosterone, I believe our guys out here are a bit more prone to potentially having a cardiovascular event that we need to have due diligent follow-up to ensure we minimize the chances of that. You can have testicular atrophy or infertility because we give testosterone exogenously. It shuts down our own production, and we can have issues in skin health. And even more feared is it can worsen untreated sleep apnea, which can have dire consequences for cardiovascular health. So it's important to understand the market dynamics at play when we discuss testosterone replacement. Every big city you go to now, you drive down the highway and you see a billboard advertising men's T replacement, or in an infomercial every other TV channel. This is because this is a global industry that's very profitable. This is simply a chart I pulled from a drug maker that shows how they approach testosterone replacement, simply in the growth and how do we make more awareness about this. However, we need to understand what the information we're getting and really distill it down to what are we trying to fix and is it worth it? So again, I always advocate for a very individualized evidence-based approach. In summary, I hope that today's presentation has allowed us to envision our urologic health and the next chapters of life. In upcoming presentations, we will review the many modern cutting therapeutic options and minimally invasive techniques to optimize these aging-related conditions. In my career, I have seen unparalleled innovation, breakthroughs, and discoveries in the field of urology, and I am very optimistic for the future of urologic health in our community. Like I say, there has never been a better time to be a urology patient than today. Thank you for your time. We'll transition now into the Q&A. All right.
Okay, we have some good questions.
All right.
Does biking often cause damage to the prostate?
Yeah, that's a great question. Typically, I'd say that when biking done correctly, it should not. However, there, in fact, have been studies regarding biking and prostate health. In fact, in one of the Ride the Rockies tours over a decade ago, they measured men's PSAs before and after the tour, and they actually found no significant changes in PSA. And if you are experiencing issues from your prostate that you're correlating with riding, we probably need to make some bike adjustments, fashion adjustments to account for that cause. With that said, if you are also associating prostate issues with biking, you may have an enlarged prostate that's more prone to issues from biking. So it's worth getting checked out with us.
If you do a surgery to remove part of the prostate, open it up, what's the likelihood that it returns?
That's a great question. That's a very individualized question as well. I think the biggest way to think about that is how much longer does the prostate have in time to grow? And as time goes on, there's a higher chance the prostate can regrow and block the channel. But in general, there's probably a lot of hormonal influence, again, that we can't fully explain. There are drugs in theory, such as finasteride, that may theoretically reduce prostate regrowth. But again, do we want to be giving medications that alter hormonal profiles just for that thought? So,
can you briefly discuss the pros and cons of aquablation specifically?
Sure. So aquablation is a treatment for BPH that is essentially resecting that prostate, the donut hole from the inside out, using robotic, water jet, heat-free automation and technology. And the pros in general is that it's very efficient. It saves time under anesthesia because we have a robotic system performing that. A second advantage is that using the ultrasound technology, we're resecting more tissue than we ever have before, rather than just our direct vision. And as a result, it is lasting the test of time longer for men, having better symptoms at 5, even 10 years now that the data is suggesting. The last, or the other reason is there's a higher chance of preserving ejaculation or sexual fluid with this procedure due to the ultrasound precision. And the last concept with it is that because we're using a high pressure water jet, as opposed to energy, electricity, heat, lasers into a confined space, there should be less inflammation, less scarring in that area over time and maybe better prostate healing. So those are some of the theoretical concept with that as well.
If you have a sustained elevated PSA over time, does it always turn into prostate cancer?
Good question. The answer is no. I don't think it always turns into it. But prostate cancer, as we discussed, can, as just general get older, develop. In virtually all men, we need to approach it like that. And what that means is, as probably time goes on, PSA becomes maybe less and less of an accurate indicator for prostate cancer, as there can be tremendous variability, difficulty in interpretation for us. So thankfully, in the modern era, we have many other tests, non-invasive tests from urine, blood-based, and imaging, such as MRIs, to stratify and to look into the prostate a bit better than just PSA alone. But yeah, I think that's answers it.
What can be done to delay the onset of declining bladder health?
Great question. I think some of the things is what I see oftentimes is men are for a period of time trying to put a Band-Aid on the problem in terms of controlling their urinary symptoms. And what that means is guys may start to dehydrate themselves because they know that if they drink, they're going to have problems urinating and don't want to drink water all day. Or they're purposefully suppressing the urge for urination because they're feeling it and don't want to pull over or don't have access to a bathroom. And that can lead to things such as bladder stretching, even increased risk for infections. So the bottom line is urinary symptoms guide one. But another concept here is that sometimes the process is so gradual in bladder health that we don't even have symptoms telling us that there could be an issue. And what can be done in that situation is discussions with your primary care doctors. Some primary care doctors even check to see how much urine are you holding on to after you urinate. And as urologists, we actually have non-invasive tests that can measure your urinary flow and bladder pressure. So it is a great concept, great topic that, yeah, I think we need to start talking about these issues earlier and earlier.
As you know, after a urologic surgery, there's often some urinary symptoms that come around after the surgery. Can you explain why that happens?
Yeah, good question. In general, a lot of urologic procedures and surgeries are done minimally invasively or endoscopically, which is great. No incisions or cuts on anyone anywhere, minimal downtime, and even minimal recovery overall. But with that said, we have to instrument the urethra to get to the prostate in many situations, or urologic procedures even. That in and of itself can be irritating, obviously, under anesthesia with the period of healing. And of course, prostate procedures that involve resections, reshaping of it, cause a period of irritation and inflammation. At the cellular level, what is happening is the prostate needs to re-epithelialize and put its healthy mucosa tissue over those periods of inflammation. That process can sometimes take weeks, and in certain situations, even months for it to fully go back to its normal state. But that's essentially what's happening.
Since we mentioned aquablation earlier, is that covered by Medicare?
Totally covered by Medicare, no issues. Despite us being one of the early adopters for this, we really only try to bring these services when it's mainstream and fully covered. Otherwise, what's the use?
Do severe bladder tuberculations, like you mentioned earlier, do they cause overactive bladder type symptoms? So frequency, urgency, getting up at night?
Yeah, that's another great question. So at the we call histologic level, meaning what is happening in that tuberculation. Yes, it's thought that is trying, in that specific area of the bladder, is probably trying to generate more pressure or squeeze harder. And as a result, we know urgency, frequency, nighttime urination are symptoms of the bladder trying to squeeze harder. So in general, as urologists, yes, we may interpret that more tuberculations may have more overactive bladder symptoms and signs. But again, it's a visual interpretation of clinical symptoms, which can have a huge complexity in between. So,
okay, let's see. Sorry, reading through the questions.
Oh, no, these are great ones. I'm glad.
Is Flomax something that can be taken daily for a very extended time?
Abs-
Flomax is a very common medication.
Absolutely. And the reality is we have many men, if not majority of men, taking Flomax to treat with BPH. And it's certainly perhaps the first medication we use. Flomax, couple things I'd say about it is that it's a great litmus test, meaning you take it, you try it to see if it helps. And if it helps, it's saying that BPH is a significant contributor. And now let's start talking about this even more. So I do recommend oftentimes trialing it just to see what happens. And with that said, in terms of the long term, many men take it with virtually no side effects for decades and decades, and they have minimal issues. So this concept of bladder health and preservation, it's not that the bladder is inevitably going to end up not working. It's about trying to ensure we identify the men who may end up like that and avoiding that outcome. The reality is most men, of course, do not end up with catheters or these end stage issues, but we want to ensure that that doesn't end up being you, the individual.
Okay. If you don't mind, will you repeat the question? I think they can't hear.
Oh,
me
yeah,
well.
sure. Yeah, this last question was, can you take Flomax for an entire lifespan, or are there any issues associated with it, essentially?
Prostate specific supplements. Anyone trying to avoid medication? Are there any that you like, don't like? What do we know?
Sure.
First?
Yeah, in general, oh yeah, are there any prostate supplements that may be beneficial, ones I'd recommend, any with evidence that can help? In general, per the guidelines, there's no specific prostate supplement that has enough evidence for us to say it's worth it for y'all to go and take. With that said, the most common one, things like saw palmetto, there's probably been the most evidence behind it. And I do have some patients that take it that can help. But again, we don't want to, minimize the issues at play of the prostate bladder health and trying to ameliorate with just a supplement if you need more.
After a longer surgery not related to the prostate or urologic, a knee surgery, back surgery, sometimes there's difficulty emptying the bladder afterwards. Can you talk about that a little bit?
Yeah, that's a great question. That happens because during surgery, you've had some anesthesia, narcotics. These are known to be smooth muscle bladder relaxants. They shut the bladder down. Also, what else is smooth muscle? Our intestines. And we get a little constipated after surgery, which can have direct issues with weakening the bladder too. Further, if you were 20 years old and had surgery, you probably wouldn't have trouble urinating afterwards. But because now our bladder is a little weaker to begin with as we're older, those extra issues from anesthesia, maybe a little constipation, make it difficult and more of an issue to urinate. So yes, prolonged catheterization after anesthesia, trying to avoid that is a reason to discuss BPH.
Let's see. I'll let you address it. I know it's a long answer. If you have prostate cancer and get either surgery or radiation treatment, what are the odds that it comes back?
Sure. So if you have prostate cancer and you get treatment, what are the odds it comes back? The goal is, and most of the time is, that it's 99% cure rate, and you put it behind you. And that is really where we're at in terms of a community and screening. And we have 5-year data. Of course, as men go longer and longer, there can be issues of it coming back. Even one microscopic cell may escape. But in general, we have an extremely, when we choose to treat men for prostate cancer, we're almost always treating in a localized curative intent. And the goal is always not, as much to 100% as possible. And we usually do achieve that with almost all men.
That's all the questions we have time
Okay. Well, thank you. A few closing announcements. Our team would love to hear your feedback on today's presentation. If you have the time to fill out a quick survey, it will appear right after the webinar has ended. You will receive an email with this recorded webinar within the next 24 hours. We have another Valley View University on June 5th at 6 p.m. with orthopedic surgeon and sports medicine specialist, Dr. Christopher George of Valley Ortho. To register for that and any other webinars, please go to vvh.org/VVU and stay tuned for future urology VVUs. Thank you all again for joining today and have a great afternoon.